Hello and welcome to clinicalpath.com. Today's topic is systemic vasculitis. Well, the title is exactly what you'd expect to see pathologically. This is going to be a disease of the vessels, and by definition, it's an inflammatory disease, which means that there is going to be leukocytes, and the leukocytes are going to infiltrate the vessel wall and damage it. Just remember the rule of vessel wall damage. There's only two possible pathologies for a vessel. It can either get progressive stenosis, leading to occlusion and ischemia, or it can weaken the wall of the vessel, leading to aneurysm and rupture. Systemic means that we get the first pattern of symptoms, which is going to be constitutional. So these are all driven by cytokines. Remember, our key cytokines in inflammation are IL-1, IL-6, and TNF. So IL-1 and TNF are going to give us our fatigue, our fever, that's IL-1, and our weight loss. And then IL-6 is going to give us our acute phase reactants, so we're going to see an increase in SED rate, which is mostly from fibrinogen, and our C-reactive protein. After that, our symptoms come from whichever local vessel causes that area of ischemia and or rupture. So since about 2012, there's been a number of nomenclature changes. And the spirit of the thing is we're trying to get away from eponyms and go to more pathophysiologically driven names. So Wegener granulomatosis has now become granulomatosis with polyangiitis. And so the abbreviation for that is going to be GPA, granulomatosis with polyangiitis. Churg-Strauss syndrome, or Churg-Strauss vasculitis, has now become eosinophilic GPA, so it's abbreviated now as eGPA. And both Churg-Strauss and Wegener's are now combined with microscopic polyangiitis, abbreviated MPA, and these are now collectively lumped as the anti-neutrophil cytoplasmic antibody associated vasculitises, which, let's face it, that's pretty hopeless to say, and that's going to be abbreviated as AAV. So that's a whole group of the three diseases are all lumped onto that ANCA positive group. Henoch-Schönlein purpura has now been changed to IgA vasculitis, which I think is a much better improvement, and that's then going to be abbreviated as IgA vasculitis. So through the rest of this talk, I'll sometimes refer back to the old eponymic names, but I'm going to try to stay to the discipline of the new, more pathophysiologic nomenclature. So the vasculitides are all diseases of immune dysfunction. And there's basically three patterns of immune dysfunction. The commonest one is going to be immune complex disease. The pathophysiology of immune complexes means that we get antigen antibody complexes that then deposit in the vessel wall. And in the vessel wall, they're going to activate complement. And so once you get activation of C3a and C3b, C5b, those are going to be our anaphylactins, and then they're going to attract both inflammatory neutrophils and macrophages. And remember, these have all of the serine proteases and all of the lysozymal enzymes, and so that's going to cause our vessel wall damage. Remind yourself, two patterns of damage are going to be progressive stenosis from buildup of clotting factors and edema and debris, or it's going to be weakening of the wall, which is going to lead to aneurysm and possible rupture. The second inflammatory pathophysiology is T-cell mediated. And this is going to be related to the formation of granulomas. And a granuloma, by definition, is a discrete aggregate of epithelioid macrophages. But remember, when we say epithelioid, that's the pathologist's morphologic appearance, which means a macrophage which has plumped up and has very pink to orange cytoplasm. But in immunologic terms, these are activated. So when we talk about activated macrophages, remember the T cells are going to be activating these through interferon gamma. In general, the activation processes are poorly understood, so they're just all lumped under cell-mediated granulomatous processes. And then the last of the great immunologic mechanisms are going to be our anti-neutrophil cytoplasmic antibodies. So this is going to be our family of antibody to the cytoplasm of neutrophils associated vasculitides. So these are always going to be lumped as the AAVs. Again, no one knows what triggers the activation, but the two proteins that are involved are going to be PR3 ANCA. PR3 is a protein serase found in the cytoplasm, and this used to be called C-ANCA. And that's going to be present in our granulomatosis with polyangiitis, formerly Wegener's. And then the other important one is going to be myeloperoxidase ANCA, which formerly used to be called P-ANCA, which is going to be associated with the microscopic polyangiitis. And then our eosinophilic ANCA really isn't highly positive for this, and we see them mixed in about 40%. But nonetheless, they all have this association with the anti-neutrophil. And the pathology of this is that you get a neutrophil here, and then we draw in the multi-lobe nucleus of it. It's the cytoplasm that has the protein in it. And so when you see the cytoplasmic immunofluorescence test, you're going to see the negative outline of the nucleus. But this makes for a highly sensitive neutrophil, and when that neutrophil bumps against the vessel wall, it activates it in situations that are poorly understood for the triggers, but it's the actually circulating neutrophil that's going to cause the damage. Okay, well, there's lots of vasculitides. The name and understanding of them has changed profoundly over the years, and I think one should limit what one learns to this list here. You're certainly welcome to learn more, but these are the ones that you have to be able to talk about. And you can see that generally speaking, people divide them by size. So large arteries, you remember these are our elastic arteries, and that refers to the aorta and the first branches. So that when we talk about giant cell arteritis or temporal arteritis, we're talking about the carotids. But don't think that the aorta is not involved. If you go actually looking, about 2/3 of them will have aortic involvement. It's just not symptomatic. Takayasu's predominantly involves the aortic arch, and again the primary branches. So this is where we're going to pick up the subclavian and the painful arms. Medium arteries are your muscular arteries, and you can think of these as the named arteries. Kawasaki actually is a syndrome, meaning a group of seemingly unrelated symptoms and signs, but the key muscular artery obviously is that 20% of these patients get involvement of coronary arteries, and 1 to 2% will die of infarcted heart. Polyarteritis nodosa can involve lots of different arteries, but the two commonest are going to be the renal arteries and then the mesenteric arteries like the celiac and superior mesenteric artery. Small arteries, remember, have very small numbers of smooth muscles, and they don't have an internal elastic membrane. And there are 3 diseases here we're going to pay attention to. Granulomatosis with polyangiitis, formerly Wegener's. This is going to be the triad disease. Upper airway, which is going to be sinus, lower airway, which is going to be lung, and then the kidney, which is going to be rapidly progressive glomerulonephritis. IgA vasculitis, formerly Henoch-Schönlein purpura. This is going to be skin, which is the palpable purpura, plus any 2 of the following 3, involvement of mesenteric arteries, involvement of synovium, or involvement of the kidney as a glomerulonephritis. And then Berger's disease is one of these quirky little diseases that's related to cigarette smoking. And what's unique about it is it's not really even a vasculitis, because what it really is formation of a inflamed thrombus in the vessels. So it's really a disease of coagulation, but the obstruction then leads to involvement of the distal arms and legs with ischemia and breakdown of skin. So I think those are the 7 diseases you've got to be able to do. You can certainly add in more, but those are mandatory. And as well, remember, you've got to differentiate between the diseases that are granuloma, the diseases that are immune complex diseases, the IgA disease, and then the ANCA diseases that form granulomas in Wegener's disease. Okay, so let's get started in the diseases. Nothing special is going to follow now, so don't feel there's anything magical going to happen. Once you've got the organization and you've got the pathophys, now it's just a matter of going through and understanding the specific diseases, and you can see we're going to have a very orderly approach to it. So giant cell arteritis. Epidemiology. The single most important fact of giant cell arteritis is the age. It's a disease that occurs in older people. If you have someone that's under 50, you better reconsider that diagnosis. There is a significant genetic link. Certainly it occurs in family clusters and it's associated with HLA-DR4, but that's not a driving finding. The key finding is the pathophysiology. The first thing is that this is going to be T-cell mediated, so we're going to find granulomas. In fact, this is such a high link that you can actually look at serum interferon gamma levels, and they actually correlate with disease activity. So that's a pretty strong statement of the pathology. This is a disease that involves the aortic arch and the aortic arch vessels. So when we talk about the vessels that are going to be involved, we're talking mostly about involvement of the carotids. So it's not that you're not going to find other vessels involved, it's just that more than 90% of the time they involve the carotids. And you can see here this is a good chance to review the anatomy. So here we have the common carotid. Got to be able to branches coming up. So our first branch coming up is going to be our superior thyroid artery. Then we come to our lingual. Then we see our facial. And then we come to the 2 key terminal branches. So coming off here, we're going to see our maxillary, sometimes called the masseteric, and then here we're going to see our superficial temporal artery. And before we leave, look at this branch coming off the maxillary. Here's our middle meningeal artery, which is famous for its association with epidural hematoma. So it's a branch of the maxillary. And when we talk about the symptoms, the 2 we're going to key on are going to be here in the superficial temporal and here in the masseteric branch of the maxillary artery. So presentation, by far and away the commonest symptom that we're going to see is going to be headache. That's going to be present in more than 75% of these patients, and it's going to be unique because it's going to be new onset. When you're over 50 years old, you should have the pattern of your disease set. If you have new onset headaches, that's noteworthy. And they can often be unilateral. And again, that's quite distinctive when it comes to headaches. The second is going to be involvement of the masseteric branch of the maxillary artery, and so that's going to give jaw pain when you eat. See that in about half the patients, although you kind of have to ask them to draw it out. And of course, that's going to be a demand ischemia. When you have a more than 70% occlusion, that vessel can't dilate to provide more blood when we have activity. But the key symptom we're going to worry about is going to be visual loss. And visual loss comes from involvement of the ophthalmic artery. Well, you notice we did our external carotids and we didn't mention the ophthalmic artery, did we? And I saved that because I wanted to point out that here we have the internal carotid here, and the ophthalmic artery here in brown, which is a different color you'll notice, is a branch of the internal carotid artery. And so that means this isn't a disease of the external carotids, it's a disease of both carotid arteries. You're often going to see that it is the retinal branch that is involved, but in point of fact, if you really want to study this down to detail, 90% of the time, it's a different branch of the ophthalmic is actually the posterior ciliary arteries. Retinal's more like about 10%, even though that's the one you always see talked about. So I just kind of generically drop it back and talk about occlusion of the ophthalmic artery. On physical exam, the key thing that you're going to look for is, can you find the temporal artery? Because the temporal artery is actually palpable. You can feel it where it crosses the zygoma arch. And if you actually put your finger on your zygoma arch and lightly press back towards the pin of the ear, you can feel it pulsing there. And when you palpate that in your patient, it's going to be thickened and it's going to be tender. The other thing on physical exam is actually the temporalis muscle, because ischemic muscles hurt. And when you palpate on them, they can be tender to palpation. So make sure you put your fingers on the patient's temples and see if that's tender as well. Well, diagnosis. Remember, this is a systemic inflammation. So we're going to see the effects of IL-6 with the acute phase reactants. So we're going to see an increase in SED rate, which is mostly driven by fibrinogen. And these are going to be really spectacularly high SED rates. You're going to see SED rates over 90 centimeters per minute. And that's going to be a marker. If that SED rate's normal, you've pretty much ruled out a systemic vasculitis. CRP works well too. It's just an acute phase reactant like ESR. But the key thing that you've got to do is you've got to actually biopsy and prove the artery. And so the artery that we biopsy is the superficial temporalis muscle. And you've got to prove in it that you can see granulomatous destruction of the artery wall. So biopsy is mandatory in the diagnosis. The treatment, remember, you start the treatment early, before you even get the biopsy results. You get the biopsy done stat, and then you start your treatment. And basically the treatment is going to be steroids, and it can go on for a surprisingly long time. So you're going to start higher at 60 milligrams, and then you're going to taper that quickly down to about 10, and that can be maintained for as much as 9 to 12 months. But in general, you're going to get a good response. Tachyassus is the other of our large vessel diseases, and this is going to be involving the aorta and its primary branches. So that's going to define our disease. And when we talk about what it's going to look like, that sounds a lot like it is giant cell arteritis, doesn't it? So the key difference is going to be the epidemiology, in which the age is less than 40 years. So when you start to see this aorta primary branch overlap with giant cell arteritis, most of the time we're going to be over 50, we're going to call it giant cell arteritis, and under 40, we're going to call it Tachyassus. Other features, this is 90% female, and it is commonest in Asia. So you're going to see lots of people say it's commonest in Asians. Well, yeah, there's lots of Asians in Asia, really referring to the geography, not the ethnicity. When we talk about the pathophysiology, we know that this is a granulomatous process. Therefore, you know that it's got to be T-cell mediated, because granulomas are activated macrophages from interferon gamma. This is going to involve the key arteries, which are the branches. That's going to be my patient's symptoms. So by far and away, the commonest artery involved is the subclavian, which is involved 90% of the time. So therefore, the patient is going to present with arm symptoms. Remember the rule of stenosis, 70% gives me a demand ischemia, so the arm is going to either go limp or hurt when being used, and greater than 90% is going to be ischemia at rest, so the arm is always going to hurt. The next artery involved is going to be the common carotid, and you're going to see that involved about 60% of the time. And so, of course, that's going to obviously involve the eye, but it can even cause strokes. Next is going to be the abdominal aorta, which is involved about 50% of the time. And that's just basically going to give us pain. And then the last we're talking about is going to be our renal artery, which is involved about 40% of the time. And obviously at 70% occlusion, that's going to give us hypertension, and at greater than 90% occlusion, that's going to give us failure. So when we talk about who we're expecting, at the end of the day, greater than 90% is about all, and so we're going to mostly be keying on the fact that there are arm symptoms. Okay, so symptoms are going to follow the vessels that are involved. Always get the time frame right. This is a subacute presentation, which means it's going to progress over weeks to months. It's going to have constitutional symptoms first. This is a systemic immune disease. So constitution present first, and constitutional symptoms in immune diseases are always driven by the cytokines. So fever from IL-1, and then weight loss and fatigue from our TNF and other cytokines. And then we look at our local vascular complications, and for early first learning, that's going to be our subclavian, so we're expecting this to be symptoms of the upper limb. On physical exam, remember you can get abnormal flow, so take your stethoscope and listen over the key vessels, in this case the aorta and the subclavian, and see if you can hear a bruit. With involvement of the subclavian artery, you might get a blood pressure differential between the two arms. If you can demonstrate a greater than 10 millimeter mercury difference between the two, remember here blood pressure is down a little lower at the level of the brachial artery, that tells you that asymmetry correlates with stenosis. Diagnosis: in the lab we want evidence of a systemic immune inflammatory disease. So we're going to see an increase in SED rate, which is really a marker of fibrinogen, or C-reactive protein, but both of these are acute phase reactants, which are markers of IL-6 activity, an inflammatory cytokine. But at the end of the day, we're really going to go to imaging. You want to take a look at the vessel, and you want to show that it's got somewhere between stenosis, narrowing, going through to occlusion, which is closure. And the treatment, as always, whenever we talk about immune modulating, these are going to be glucocorticoids with high doses to initiate, and then low doses for a long time, up to years, because these are chronic diseases. So managing all the complications of the glucocorticoids becomes the major problem after the immune process is brought under control. Kawasaki disease. If there was any disease I could go back and do differently in the books that I've written, it's my understanding of Kawasaki's disease, because this is actually the most common cause of cardiac disease in children that's acquired. And for all the time we've spent on rheumatic fever, we don't get rheumatic fever and rheumatic heart disease in the first world. It's a third world disease. So when you talk about the disease of our children, it's going to be Kawasaki's disease. And we're just now starting to recognize how prevalent it is. So if there's anything I could do to reorient your brain, Kawasaki's disease really matters. And what we want to think about is what it used to previously be called. It previously used to be called mucocutaneous lymph node syndrome. And that might be ponderous, but it really captures disease. We're looking at disease that involves mucous membranes, skin, and lymphadenopathy, in addition to the vasculitis. So when we talk about the immunology, this is actually a disease that's highest in East Asia. If you take a look at Japan, for example, Japan, you see it in about 1 in 100 children, which is 10 times as often as we see it here in the US. And then this is a disease of young children. So the age, 90% will be less than 6 years. So this is a disease of little tiny children, sort of in the 3 to 5-year-old group. Pathophysiology, this is an immune complex disease, so we're going to see neutrophils from the complement activation. It does appear to be transmissible. No one knows what that causes that, but you can see that it actually is seasonal and increases in winter. Beyond that, no one really knows the cause. So presentation. So pay attention, because this actually is a disease you want to be able to see and recognize because of its risk of death. The presentation starts with a high intermittent fever for more than 5 days. So that's how it starts. Unexplained prolonged fever. And then we go to the other entities of the syndrome. If you have 4 of 5 of these following findings, you've established a diagnosis of Kawasaki's disease. The first is going to be conjunctivitis. Yeah, well, how common do you think that is in little kids in viral season? And we can see a picture here of it because it's important you get it right in your head. You notice the first thing is it's bilateral, and the second thing is there's no pus. And that's important because the commonest causes of conjunctivitis are going to be bacterial infections and allergies, and so they're going to have acute inflammation with discharge. You don't see that in Kawasaki's disease. It's a systemic immune disease. The second thing we're going to see is mucositis. And too bad this picture doesn't go down a little further, because if we could draw in the lips here, what we'd see is we would see cherry red lips, and if we could look into the tongue, it would be a bright red tongue. And so that's our so-called strawberry tongue. But looking in the mouth, the whole mouth is lit up in bright red. If you're really good at this, and I'm not, but if you were really good at this, they say you can sort of look at the mouth and make the diagnosis. Third parameter is a rash. There's nothing particularly distinctive about the rash, but you find it down around the groins and the legs. So any kind of lower body rash will establish one of your criteria points. The hands and the feet have distinctive palms and soles because they get redness and edema. Now eventually this is going to go on to shed and desquamate, but that's not for 2 weeks, and as we'll see, that's way too late to make the diagnosis. So when you read in a book desquamation, you know that's someone that's really missed the point of the disease. It's got to be diagnosed within 9 days. And the last of this is going to be a cervical lymph node. Typically this is the sternocleidomastoid node, and if you can find one that's bigger than 1 centimeter, you're off to the races. So prolonged fever for more than 5 days and 4 or 5 of these criteria, and you've made the diagnosis. So it's a clinical diagnosis, but the investigation is important for the heart, because 20% of these children have involvement of the coronary arteries. And in fact, 1 to 2% of them will have a fatal cardiac event. So when you investigate these children, the next thing you're going to do is you're going to do an echo of the heart looking for that involvement. And yes, just like all of these, you're going to see 2 patterns of involvement. You can see stenosis to occlusion, or you can see aneurysm to rupture, just like we see with every other vessel that's inflamed. When you take a look at the lab, again, this is a systemic inflammatory disease, so you're going to be looking for the acute phase reactants of sedrate and C-reactive protein. But the urgency boils down to the treatment, because IV immunoglobulin has to be given before 10 days. That's why you can't wait till you see the desquamation of the hands and feet. You've got to get this disease recognized in the first week and treated, because that dramatically decreases the rate of coronary artery involvement. And you'll see lots of books talk about giving high-dose aspirin. No one's shown that that changes the natural history, but I'm sure it makes the mother and the doctor feel better. The key here, IV immunoglobulin before the 10th day changes the natural history. Well, polyarteritis nodosa is sort of one of these weird diseases that hangs out there and no one's really sure how to recognize it. It presents late. We make late diagnoses. So it's not a disease that you can really heavily test. The biggest thing that always comes up is its association with hepatitis B. I think that's legit because that's a really good example of an immune complex vasculitis. But otherwise, this is a systemic necrotizing vasculitis of medium-sized arteries that you don't see in any particular age group. Yes, it's adults in middle age. And remember the association with hepatitis B, that's great to test because we have lots of hep B. Pathophysiology, again, this is an immune complex disease. So we typically see segmental involvement of the arteries. The reason that matters is we're going to later say, well, why do you care that it's segmental? Because involvement of segments means I have alternating stenosis and weakening. So when we say, what's that going to look like when we image these diseases, segmental involvements means that we're going to look for an imaging pattern that has beading. So that's why we care about that. Well, what are the organs that get involved? Well, by far and away, the number one is going to be kidney. So that's not going to have any particularly acute presentations. The one that's really going to matter is that it's going to involve the GI arteries. So those are sort of lumped together as the mesenteric. So you can think of this as celiac and superior mesenteric artery. And that matters because that's going to give us pain with eating from a demand ischemia. And then the last thing that you can see is that it can involve the peripheral nervous system. So that's going to give you paresthesias and anesthesias, and that has a very broad and complex differential diagnosis. The key thing to note here is not the lungs. For reasons that are completely unknown, the lungs are spared as vessels. So who's going to walk in the door? Like all of these, they're systemic. So the first set of symptoms is going to be constitutional. So that's going to be our fatigue, fever, weight loss, muscle pains if that's involving muscle arteries. And then we're talking about what specific vessel is involved. So in this case, we're talking GI symptoms. And remember, greater than 70% will give me a demand ischemia. So this is going to be pain after eating. And if I was going to write a question testing this, that's certainly what I would do. And then the second is going to involve the kidney, which is at 70% going to give us hypertension, and at 90% going to give us failure. Diagnosis? Well, diagnosis always is best if you can make it with a biopsy. That would be preferred, but where the heck are you going to get a medium-sized artery to biopsy? They often, if they can present with kidney disease, you can organize a kidney biopsy, and in that you can see some muscular arteries, for example, the arcuate, but boy, sampling is going to be a problem. So that's the counsel of perfection, but really difficult to do in practice. When we come to the second standard that would replace it, we could do imaging, and as we've discussed, if you can show the beading of the involved artery from its segmental involvement, that's really good evidence. But at the end of the day, because this is such a non-specific presentation, we want to see the lab, because the lab's going to be good at ruling out everything. Obviously, we're going to see the acute phase reactants, so we're going to see an increase in SED rate, but we want to rule out all the other possible secondary causes of an immune complex vasculitis. So lupus is our model disease, so you want to show that they're ANA negative, that it's not lupus. And then we've talked about the viral hepatitis, so we want to show that they're infection negative, and the big ones here are going to be hepatitis B and C, and HIV has an associated vasculitis. So the lab is going to be mostly important for ruling out the known causes of secondary vasculitis. Treatment is immune modulation, so perfectly straightforward, you're going to put them on steroids. So granulomatosis with polyangiitis, or GWP, is wrong. It is granulomatosis with polyangiitis. And remember, this is formally called Wegener disease. Epidemiology, really none that's useful. Like it's older adults, like every other disease in the world. So nothing specific in the epidemiology. The presentation, remember, is going to start with constitutional. Low-grade fever, weakness, fatigue, and weight loss. But when we talk about the organs specific, now we're talking about the critical triad. So in the upper airway, we're talking about a bloody sinusitis. And the bloody part matters because when you're talking about blood in something, blood tells you that there is necrosis. And the necrosis here is from the occlusion of blood vessels forming ulcers. When we talk about the lower airway, this is going to be our lung, this is going to be our hemoptysis. And you notice we're back to this theme of blood again, blood indicating that there is necrosis. And the third organ that's going to be involved is going to be the kidney, and this is a rapidly progressive glomerulonephritis, so that's going to present as hematuria, and the rapidly progressive means that they're going to have renal failure in less than 12 weeks. So when we say the triad, bloody sinusitis, hemoptysis, and hematuria with rapid renal failure, that is the triad of granulomatosis with polyangiitis. So what are you going to see on physical exam? Really, it just depends on what specific vessel's involved. So if it's sinuses and lung, you're really not going to find much. It's about ruling out other causes. When we talk about the lab, obviously if you could do a biopsy of the affected artery, that would be fine. Hard to biopsy sample vessels. The second you could do is you can actually biopsy the sinus, and if you could show a granulomatous inflammation, that would be very convincing evidence. But at the end of the day, we're going to key heavily on the lab, and that's going to be our PR3 ANCA, which is the currently accepted name for what's commonly written as C-ANCA. So it's a lab-based diagnosis. If we did a chest x-ray, remember this is necrotic, so we should see, in addition to all the other problems, it should be cavitary from the loss of lung tissue. If we did a biopsy on the kidney, remember this is going to be rapidly progressive, so we're going to see crescent formation in the glomeruli, in which we see this proliferation along the outside of the parietal epithelial cells. That is true in every rapidly progressive glomerulonephritis of any cause. When we talk about the treatment, obviously immune modulation always anchors on steroids, but this is a life-threatening disease, so it's steroids plus a combination of immune modulatings like cyclophosphamide, methotrexate, and recently rituximab. And so you'll see that various institutions will use these in different combinations. Remember that this is a deadly disease without treatment. You're really talking about a 90% mortality in less than 2 years without treatment. However, with treatment, they have about an 80% 5-year survival. So this is a really serious disease that responds really well to treatment. IgA vasculitis, formerly called Henoch-Schönlein purpura, is the most common vasculitis in children. So Kawasaki's is the most important cause of acquired heart disease in children, but IgA vasculitis is the most common disease that you're going to see in practice. Epidemiology, age is a hugely important factor here because the age really peaks between 5 to 7 years. So disease of grade 1 basically. You see it more commonly in boys than girls, and it is seasonal. No one can tell you the exact trigger, but about 1/2 of the children have a preceding upper respiratory infection. So winter season, you're going to see a lot more. Pathophysiology, this is an immune complex disease, so you're going to see neutrophils. Neutrophils typically on biopsy are called leukocytoclastic because they tend to break up and leave debris all over the place, so leukocytoclasis, clasis to break apart. But remember, the key is it is IgA. Really, no other vasculitis does that. And so yes, there's some sort of environmental trigger because obviously this association with infections, but whatever that environmental trigger is, it's not well understood at this time. So presentation is reasonably subacute, so it's going to occur over days to weeks, and by far and away the commonest presentation is going to start with the skin, where there's going to be palpable purpura. And palpable matters because when we talk about purpura, there's 2 patterns. If it's palpable, it's because there's swelling from edema, one of the hallmarks of inflammation. So palpable purpura is inflammatory. Non-palpable purpura is associated with low platelets and leaking from the vessels. So palpable purpura and 2 of the following 3. Either they have abdominal pain, presumably from involvement of the mesenteric arteries. They have involvement of the joints, so that they can have arthralgias, painful joints, or frank arthritis. And last but not least, they have glomerulonephritis, so they're going to have hematuria. And if you did a biopsy of the kidney, which you wouldn't, but if you did, it would be an IgA glomerulonephritis. The treatment really is watchful waiting. This is benign, self-limited. Should resolve over about a month. Just to finish up is Buerger's disease. It's a quirky disease related to heavy cigarette smoking, so obviously it's really been dropping in incidence and prevalence in the United States. It used to be called thromboangiitis obliterans. That's an alternate name for it. And I really like that name better because it tells you what it is. Thrombosis of the blood vessel causing occlusion. So I think that's a way better name, and I hope they switch over from Buerger's disease to do that. Epidemiology, obviously this is a disease that's associated with very heavy smoking. So you should be able to look at your patient and see the nicotine stained. And you got to smoke for 20 or 30 years because we see the age group is in the 40 to 50 age group. Pathophysiology, this is considered to be a hypersensitivity to tobacco products, especially cigarette smoking because that has such deep inhalation. It's an inflammatory thrombi. So think about what that says. Inflammatory thrombi is not truly inflammation of the vessel wall, is it? Because thrombi is actually in the lumen of the vessel, and that's what's going to give the occlusion. And you can prove that if you actually got to biopsy one of the arteries, you would see that there's sparing of the internal elastic membrane, which is what pathologists always use as a hallmark of destruction. And so what that tells you then, this must be endothelial dysfunction. And the endothelium is key in regulating so many functions in the body, but obviously one of them is going to be coagulation. So whatever that hypersensitivity to the tobacco product toxins is, it damages the endothelial cell, leads to coagulation difficulties, and an occlusive thrombus. So presentation is driven by the vessels involved, and that includes both arteries and veins. So if it occludes the peripheral arteries, then one is going to see digital pain if it is greater than 70%, and that's going to go on to ulceration when the occlusion is greater than 90%. At the level of the distal veins in the limbs, we're going to get a superficial phlebitis. So you're going to see the hard thrombi, which is going to present as nodules in the skin. So it's a thrombotic coagulative disease of both arteries and veins. And over time, it will progress proximally. So you can go from involvement of the fingers to the forearm and up. Investigation, well, it's really just a clinical diagnosis. The important thing is to rule out the other diseases that could mimic it. So obviously you want to rule out atherosclerosis. That would be involving arteries. And you want to rule out a hypercoagulable state. So for example, factor V Leiden or prothrombin G210, because that's what would give the thrombosis of the veins. You want to rule out a systemic vasculitis. So useful would be go looking for those IL-6 markers. So SED rate and CRP should not be elevated. This is a coagulation disease, not an inflammatory disease. And then you want to rule out the rheumatologic diseases, and the two primo diseases would be lupus, so get an ANA, and rheumatoid arthritis, so you could get a CCP and rheumatoid factor. You can certainly go on and get the full workup for scleroderma and all the other diseases. And obviously the cornerstone of treatment is stop smoking. Okay, so that brings us to the end of this disease group. I think the key thing to recognize is the nomenclature is changing, so practice the new names and then learn the 7 diseases on the table, and I think that should do you for this complex and relatively uncommon group of diseases. Thanks for listening.